Hello, good morning, friends. Welcome you all. Today is our 10th webinar in the series of 12 webinars, which is brought to you by GP Clinics through our own digital platform, docizlive.com. I am Dr. Anupam Agarwal, publishing GP Clinics, which is published every month for last 13 years, sorry. Today's subject is abdominal distension. Please don't ignore. The recordings of all the previous 9 sessions are there on our website, gpclinics.in, and on GP Clinics YouTube channel. The summary of each session with questions and answers is published in GP Clinics every month, printed issue. The speaker for today is Dr. Y.K. Amdekar again. He needs no introduction. For all those who have joined new, Dr. Amdekar is a practicing pediatrician for last 50 years. He is currently a visiting consultant to SRCC Hospital, Mumbai. He has also been the faculty to Grant Medical College, JJ Group of Hospitals, and Institute of Child Health, Mumbai. He has been the past president of IAP as well. So over to you, Dr. Amdekar, sir.
Thank you, Anupam, and good morning, friends. Today we are going to discuss a topic on abdominal distension. And from a very benign condition to very serious condition, there are a lot of such spectrum, and we will just go through that. Can I have the slide, please? Now, as usual, we will first look at our basics so that on the basis of that, we can develop our discussion subsequently. I think abdominal distension commonly relates to intra-abdominal problems. Okay, but sometimes it could be also in the abdominal wall itself. And I think it is important to make sure that you have no extra abdominal problem in the abdominal wall, which is certainly not common, but keep in mind. Patients often complain vaguely of bloating, sensation of fullness, and often complain of gas or swelling in the distant or different quadrant of the abdomen. Rarely, the swelling may arise from the abdominal wall as itself, as I said, and we will give some examples of each of that. Now, common causes, I am sure all of us as undergraduate were taught 5 F's, which is flatus, feces, fluid, fat, and fetus. Of course, besides, there are localized swellings like an organomegaly or a localized lump. The first 5 F's really are of general or specific central predominant, and we will not discuss much about the fetus and a fat because that's not really a presentation of an abdominal distension in itself, and we will discuss the rest of them. But what is important is there is often a functional abdominal distension that may result without gas and as a result of gut-brain interaction due to many issues like mental stress. So almost like abdominal pain is a feature of a functional origin, constipation is a feature of functional disorder, so also bloating, abdominal distension, so-called gas is also a functional element. So with this in mind, let's get to the next slide, please. Now this is for your interaction. Which of the following statement is wrong? Abdominal distension exists without intra-abdominal pathology in normal infant, malnourished child, obese child, or none of the above. Your time starts now. Very good. Uh, most of the answers are reasonably shared But of course, the majority feel none of the above is wrong, and there you are mostly right. Okay. The point I wanted to make is what looks like an abdominal distension to parents or to the patient, and therefore they come to you and me, may not really be even an abdominal distension by itself. So I want to define abdominal distension at this point of view, and then you will understand that how a normal child, malnourished child or obese child may also have a protuberant abdomen or a distended abdomen, but it is not really distended. What does it mean by that? A typical pathological or whatever the cause, but something that you cannot ignore, the abdominal distension is best assessed when the patient is lying down. And if you are lying down and your abdomen goes above your chest level, it's called abdominal distension. I'm sure majority of the doctors have a protuberant abdomen, but it's not an abdominal distension of any concern because when you lie down, your abdomen does not go higher than the level of the chest. And a typical abdominal distension that the physicians need to confirm is when a patient is lying down, when the abdominal girth goes higher than that of the chest. And in all these situations, like a normal infant, a malnourished child, and an obese child, abdominal distension is not real but apparent in sitting or standing position. And that's why just take a note of this fact of abdominal distension. Let's have a next slide, please. Having discussed the basics of abdominal distension, 5 Fs, of which 3 Fs are important, and the localized abdominal distension like an organomegaly and also the lumps and even the functional component, which is often vaguely called as gas, etc., and knowing that abdominal distension must be confirmed of significance in a lying down position, let's look at a simple clinical approach. I'm sure, as usual, the detailed history is very, very important, and onset, progression, duration are all important factors. I'm sure all of you have been attending these webinars and looking at the GP clinic journals, have been specially primed and sensitized to learn continuously, and in a real sense, a continued medical education, CME. I'm sure this kind of approach is nothing new to you, but just to recapitulate again, what happens suddenly is often surgical, but also may be medical. Okay. And what happens gradually is mostly medical, but may often be surgical. So the rule exists that if there is a sudden abdominal distension of just few hours or a day of onset, first rule out a surgical problem and keep in mind a not so common but just existent medical problem. On the other hand, somebody says, I've been having a gradually worsening abdominal distension over a long period. It's almost always medical, but don't forget some rare surgical situation. We both see them, but as a rule, your thought process should be more the acute. And obviously, there would be many other symptomatology along with acute abdominal distension, surgical, like typically vomiting, either bile stained or non-bile stained. There could be constipation. In a medical situation, there could be, again, similar situation, but not vomiting as a predominant feature. And when you talk about a gradual onset one, sometimes a chronic or a subacute intestinal obstruction may behave with a gradually worsening or persistent abdominal distension, but mostly it's a medical cause. And of course, the lump could be medical, surgical as well as the organomegalies are almost always medical. So this much then about the onset and the duration further. Progression is very, very important. For example, flatus waxes and wanes on abdominal distension. When the gas is passed, the abdomen gets a little lower. Then, when the gas is not passed, it's all distended. Same thing happens with the constipation, chronic constipation, when it is relieved by whatever method. The abdomen goes down a little, becomes flat, and then again, after 2 3 days of not passing stool, the person complains of abdominal distension. So, always take a note whether it is persistent or waxing and waning, and if it's waxing and waning with, is it passage of gas or passage of stools? And then, of course, many accompanying symptoms like, in particularly, vomiting, diarrhea, constipation, pain, abdominal pain. The most common symptom with an abdominal distension, and a good difference between a painful abdominal distension and a painless abdominal distension. And even in painful abdominal distension, acute severe painful abdominal distension has again a very mild discomfort, but yes, mild pain. And I think abdominal pain going along with abdominal distension or absence of pain totally would make a lot of impressions on our clinical judgment, besides, of course, vomiting, constipation, diarrhea, and many other illnesses unrelated to a particular organ or otherwise. Like, if it's a liver problem with abdominal distension, you may have jaundice as well, and so on and so forth. We will give examples of each of this to kind of make us understand, but just to make a point about accompanying symptoms, painful or painless is one important aspect. And of course, the other aspects are whether the health is deteriorating over time or a patient is otherwise fine, which reflects on a physical examination. And most important physical examination again is whether the distension is generalized or localized. If it is localized, which quadrant of the abdomen looks distended more than the rest of it? Even in an abdominal generalized distension, there could be some localization even in a generalized abdominal distension. Like, in a generalized abdominal distension, if the flanks are more distended, then the central part of the abdomen, you are mostly dealing with ascites. On the other hand, in a generalized abdominal distension, the central part is more prominent, then you may have a lump in the center of the abdomen. So take a note, generalized, localized, in quadrant, even in generalized, localization in a generalized abdominal distension. There, of course, you will go by consistency, tenderness, and all that. And I think that would possibly get you onto a correct impression. And percussion is an important physical modality because it might differentiate between a solid and a cystic or a liquid kind of collection, and therefore an impaired note, a dull note, stony dull note, or sometimes there could be air, like a gaseous abdominal distension, where the percussion note is tympanic. Auscultation doesn't help a great deal, though. If there are excessive peristalsis, you might consider a obstruction, and if there are no peristalsis at all, then you might consider some problem where intestines are not moving at all. But that's not a common feature, and that's not what you greatly depend on. But yes, auscultation also is a part of a clinical approach in an abdominal distension. So having said this about the clinical approach, let's get about, as usual, the cases that we will discuss, and each case will give you some kind of extra point on which you would make a correct diagnosis. And I think, as usual, that would be stimulating our gray cells. Let's have a next slide, please. Now, this is your first case. This was a young adult who presented with acute onset of severe periumbilical abdominal pain and mild fever and one vomit which contained food particles, besides complaining of abdominal distension. Now look at this. Painful abdominal distension. Okay, take a note of this. And on physical examination, you found a sick person with mild abdominal distension, not major. Look at this. His main complaint is pain, but he has also abdominal distension and it's tender all over. Now, what is your probable diagnosis? Is it an acute GI infection? Is it an acute intestinal obstruction? Is it acute peritonitis? Or is it acute appendicitis? Your time starts now. Excellent. A good start to our webinar today. Majority of them uh, are right. Uh, most of you have been talking about acute appendicitis, and while all other three conditions are closely related, and that's what I wanted to bring out every time. Now, look at the story. Out of fever, vomiting, and abdominal pain is severe and the major symptom. Please take a note of that. In acute gastrointestinal infection, pain is not a major feature. Okay, but there could be change in the bowel pattern and vomiting may be mild. In peritonitis, fever and sickness is the main thing. Vomiting and abdominal pain varies, but the fever is higher. So, if there is a predominant symptom in acute intestinal obstruction, fever is rare. Okay, and therefore, the right answer is acute appendicitis. But what I wanted to bring a notice also is in earlier webinar on abdominal pain, we have done this, that acute appendicitis starts with the periumbilical pain. Okay. And therefore, all four conditions are close to each other, but a small difference. Acute GI infection at this age is not common with high fever or a low fever, yes, but diarrhea largely, and acute intestinal obstruction has no fever. Acute peritonitis has extreme sickness and high fever, and therefore small difference. I want to bring one point to your notice that all other three problems need to be very carefully ruled out because in medicine there is no sacrosanct, but we are going to discuss with what majority of the times is likely to be true. But yes, you are right that there is always a patient who does not follow the common presentation the way we expect, and therefore always rule out such condition, but primary focus would be an acute appendicitis, right? Can I have the next case, please? Now, the next case is something similar. This child is a 10-year-old presented with acute onset of severe abdominal pain with fever and vomiting for the last 3 days. He was very sick looking. He had a tender right iliac fossa. So he was diagnosed correctly as appendicitis and he was suggested surgery. The patient refused, but the next day the pain disappeared, but abdominal distension persisted. What is your action on this patient? Your options are review the diagnosis of appendicitis, consider complication of appendicitis, consider urgent surgery, or wait and watch. Your time starts now. Very good. Almost majority of you feel it's a complication of appendicitis, and therefore you are right if you said you consider surgery, because when you consider a complication of appendicitis, naturally you are bound to go for surgery. And what I wanted to bring a point again, which we did discuss during discussion on abdominal pain, that if appendicitis is not treated at the right time, there could be a gangrene developing in an appendix. And when gangrene develops, the nerve endings are also destroyed and there is no pain. But the distension and a sickness continues, in fact, worsening. And you are right, this child had a complication and therefore he also required surgery. So majority of you got right, right? These were two conditions where you had a painful abdominal distension. Naturally, pain was so severe that the major complaint was pain, but on examination, there was also an abdominal distension. But in this child, abdominal distension even worsened where the pain disappeared completely. And that is the way we wanted to discuss this issue of abdominal distension. Let's get to the next slide, please. Now, the next slide is a young child of a year old. Now, this infant presented with generalized abdominal distension and a poor weight gain over the last 6 months. So, this complaint of generalized abdominal distension and losing weight has been going on for a long time. On direct questioning, constipation started even earlier than that. And very early in infancy, while he was on exclusive breastfeeding, the mother had noticed constipation, and which was brought up by direct questioning about stools in this child. And now this baby continues to be on breastfeeding plus on cow's milk with occasional rice and dal. Look at this whole story, gradually progressive abdominal distension with constipation beginning very, very early in infancy, even while on exclusive breastfeeding. And now your options are, one, it's all due to malnutrition. It is all due to feeding errors. It is due to intestinal obstruction, or it is due to hypothyroidism. Your time starts now. Good. I think, again, as usual, I I like to place 3 or 4 very similar looking situations, and I can see that uh, 1/3 of you have said it's malnutrition, another 1/3 of you said hypothyroidism, but also 15% plus minus have also got into other two issues. Let's discuss each one of them. Okay, now a typical hypothyroidism is a child who has not lost weight, in fact, who is a little obese, because of mixed edema, like an adult. Okay, here is a hypothyroid who comes often with a little excess of weight or at least a normal weight. And this child has been losing weight, so hypothyroid is not the thing. And hypothyroid comes typically, the major complaint with the mother is he has a delayed milestones. Okay, so this is not hypothyroid. What about feeding error? Yes, feeding error per se would have some constipation, but when the constipation is relieved, abdominal distension is also relieved. It's not gradually progressing abdominal distension. And same is true for malnutrition. In malnutrition, because of the intestinal hypotonia as well as because of poor nutrition, if it is due to feces or due to gaseous distension, in either of the two, feeding error and malnutrition, the typical story is a waxing and waning. But if this is a gradually progressive abdominal distension generalized, then your diagnosis is intestinal obstruction. and what intestinal obstruction which is chronic at this age. And this is called as Hirschsprung disease or a congenital megacolon. The point to note further, and I am bringing this child only for all of you who have been attending this webinar regularly, which I am very sure that you are so committed to keep on learning more and more, is a breastfed baby, exclusively breastfed baby, is almost never constipated. It's a rule. And therefore, if this child started very early in infancy, the obstruction started very early, but it's not a complete obstruction. It's an aganglionic colon or a rectum, and this is known as a congenital megacolon or a Hirschsprung's disease, and this child would need surgery. This is one example of a surgical problem presenting as a chronic progressive abdominal distension. I told you it is not common. Longer the period of abdominal distension or constipation, the problems are often medical. But this is one area where a chronic problem also a chronic intestinal obstruction like a Hirschsprung disease. And often they come with abdominal distension. When they are asked about it, they come out with constipation because constipation doesn't bother them as much as abdominal distension keeps on making them uncomfortable. And on direct questioning, you get this story of constipation, right? Let's have a next slide. The next is a very senior citizen, an old man. And these are actually live cases that I heard about. I don't treat adults, but one of my friends saw this person and asked me, what would you have thought of? And I said, I will think about if this was a 14 or 18 or 20-year-old. And that is how such problems are fairly common at an older childhood age or adult or a malnourished child on one extreme and an old man who is also often malnourished at the other extreme. So this was a senior citizen who presented with acute onset of loose stools and mild abdominal distension for 2 days. He was treated and the drug used was loperamide. My friend told me that this is the drug that they often use in so-called viral diarrhea, etc. It's a stool binding agent. In children, we don't use them at all. But here, the diarrhea suddenly stopped and abdominal distension worsened. And the patient also complained of nothing else but abdominal distension. There was no vomiting or any other complaint made by the patient. Okay, look at the story. Mild diarrhea, okay. Loperamide, controlled diarrhea, okay. And abdominal distension got worse. Your options are, he has developed intussusception, he has become dehydrated and in shock, he has a drug-induced complication, or he has a metabolic complication. Your time starts now. Good. I think none of you said that dehydration and shock should be a problem. So majority felt it was a drug-induced complication, and a few said it's a metabolic complication. Yes, I think those who said it's a drug-induced complication, they possibly mean the similar thing that those who opted for metabolic complication. So possibly this is not an intussusception. Let's get back to the same slide. Yes. Intussusception would have presented with a blood and mucus in stool with acute abdominal pain. You are right. that one of the complications of a loose stool is an intussusception and suddenly the diarrhea stops. Yes, you are right up to that point. But the presentation is not just an abdominal distension, but acute pain with blood and mucus and abdominal distension. So it's not intussusception. Obviously, it's not shock. Now, could it be due to loperamide? Yes, it is. But if you thought it was due to loperamide alone, all that you would have done is to wait and watch. Okay. But consider, why does loperamide cause such a problem? Loperamide almost makes the intestinal muscles weak enough not to progress. In other words, they become so hypotonic that they don't move. The tone is gone. Okay. And in a metabolic complication, similar things happen because of a severe hypokalemia. So both are almost right answers. Typical loperamide may not cause hypokalemia, but will make a lot of change in the intestinal tone, whereas the hypokalemia also causes lowered intestinal tone, but more than tone, there is an intestinal paresis. That means the muscle of the intestine is paralyzed because there is no enough potassium. But yes, both of you are right. But the point I wanted to make is that this is one example of an acute onset abdominal distension, which is not surgical but medical. And I wanted to bring also hypokalemia because as you get old, you tend to be hypokalemic, and any small illness will exaggerate hypokalemia, especially one that is causing diarrhea, because you lose also sodium and potassium. And to that extent, both the answers are reasonably correct. The mechanisms are different. And if it's hypokalemia, then wait and watch will not work. You will have to give extra potassium, and you cannot give it orally because the intestines are not working. So you may have to give intravenously. And just a point to remember is giving intravenous potassium has to be extremely diluted in a large amount of fluid. It cannot be injected directly, otherwise the child would just die instantly with a cardiac arrest. Intravenous potassium is a dangerous drug, and it has to be extremely diluted over large amount of fluid and given slowly in infusion. And if there is an emergency because of hypokalemia, even the cardiac rhythm gets disturbed, then one may have to give intravenous potassium in an ICU setting under a cardiac monitoring. But that is just to make a point here that if you correctly diagnose this as either loperamide or metabolic, if it was loperamide, wait for a while, over a 24-48 hours, he should settle down. But if it was hypokalemia, and how will you differentiate between the two? If it's hypokalemia, there is often a bradycardia or a change in the heart rate, tachycardia, or the deep tendon reflexes are lost. So next time you find a loperamide complication like this, take a deep tendon reflex like a knee jerk, and if you cannot look at the knee jerk, and this is a child on whom if you auscultated, the peristalsis would not be heard. This was just to bring, in the last case we saw a chronic surgical problem of abdominal distension. In this child, you are seeing an acute medical problem of a severe abdominal distension. Can I have the next slide? Now, the next slide is again a young adult who presented with low-grade fever and loss of weight and appetite in the last 1 month, but there were no other symptoms. Now, physical examination showed upper abdominal distension, liver was enlarged, it was firm, the neck veins were congested, but hepatojugular reflux was absent. Heart rate was normal and there were no other signs. Take a note, low-grade fever and loss of appetite for a month, liver enlargement, upper abdominal distension, neck vein, but there was no hepatojugular reflux. Now your options are, is it chronic hepatitis? Is it hepatic malignancy? Is it congestive cardiac failure? Or is it none of the above? Your time starts now. Good. Can we have the slide back again? A typical chronic hepatitis presents with jaundice. Okay. When the hepatocytes are damaged for a long time, jaundice is the presentation besides the enlargement of the liver, and there is no reason why there are neck veins are engorged. Make a note, neck veins are engorged means that there is some venous obstruction occurring, either due to venous congestion or obstruction. So that is not right. So also hepatic malignancy may present with loss of appetite, loss of weight, but there is no reason why there is an engorged neck veins. So engorged neck veins put you to possible congestive cardiac failure, but the hepatojugular reflux is absent. So this is a condition where there is a hepatic venous congestion, like in congestive cardiac failure. The liver is congested, but there is no hepatojugular reflux, which means there is an obstruction to the venous system, and this child had a constrictive pericarditis, because of which the inferior vena cava was getting obstructed and the superior vena cava also was getting obstructed. Therefore, there was a neck veins engorged, there was a venous engorgement in the liver at both ends, superior vena cava and inferior vena cava. You had congestion, but there was no connection between the two because there was an obstruction at the pericardial level. And this was a child, this was a person who was having a tuberculous constrictive pericarditis. That low-grade fever and loss of appetite should bring you to tuberculosis more than anything. And the, I wanted to bring this point again to you because when you see the liver enlarged, always look at the veins, and if you saw the vein, always confirm whether there is hepatojugular reflux or not. This was a person who had a tuberculous constrictive pericarditis presenting as an abdominal distension with vague symptoms of loss of appetite, loss of weight. Can I have the next slide, please? The next is again a young adult who presented with gradually progressive abdominal distension, loss of appetite and weight for the last 4 months. Take a note, this is going to be 4 months. And physical examination showed a very firm lump in the, oh, I've lost the slide. Yes. Physical examination showed that there was a firm lump in the umbilical region, fairly large, not tender. Okay. Your options are mesenteric cyst, Hodgkin's lymphoma, TB lymphadenitis, or intestinal tumor. Your time starts now. Very good. I think majority of you suggested that there is some tumor of some kind. Okay, let's get back to the slide. The mesenteric cyst would never have the loss of appetite and loss of weight because it's a benign cyst. So that is out. What about Hodgkin's lymphoma and TB lymphadenitis? Yes. The point is, when you have a large central mass, it is likely to be coming either from lymph nodes or intestine. Correct. So you have rightly guessed that. However, if it is an intestinal mass coming, then generally either it could obstruct the intestine and present as an intestinal obstruction, or if it is an intraluminal mass, might even present for a while with some change in the bowel pattern, and an absence of those symptoms puts intestinal tumor a little less likely, and therefore both the conditions look alike, Hodgkin's lymphoma and TB lymphadenitis, and both can be correct. However, today the tuberculous lymphadenitis alone as a large tumor in the abdomen has not become common, and Hodgkin's lymphoma has taken over it. And the reason is that in TB, the lymph node that goes on enlarging is really a primary tuberculosis, which means that this person has got tubercle bacilli for the first time in his life. That's called primary TB. And primary TB presents with lymph node, whereas most of us in India who have lived through childhood in India and during young adult have often come in contact with tuberculous germs but have not luckily suffered from it. And therefore, when we get a disease coming out of it, it is called a secondary type of tuberculosis because I was infected long back, and secondary type of tuberculosis does not present with lymphadenopathy, and therefore today, if you see a large lymph nodes in the mediastinum or in the abdomen, first rule out Hodgkin's lymphoma, and if well ruled out, TB lymphadenitis is a possibility, and therefore I will give both of them good marks. But just to know that in today's Indian epidemiology, lymphoma has taken over tuberculosis in adults and older age, and therefore this was likely to be Hodgkin's lymphoma. Can I take the next slide, please? So the next is the next slide, please. Next slide. Next slide, please. Yes. The 10-year-old child presented with abdominal distension over the last 6 months and gradually increasing for 3 months first, and thereafter no further increase. Take a note. The increase occurred gradually over 3 months, and then it stopped increasing, but persisted. So the abdominal distension is for a long time, but increased over 3 months and then stopped increasing. Physical examination showed a very comfortable child, dull note all over the abdomen. There is no shifting dullness. Now your options are large tumor, large cysts, TB peritonitis, or ascites due to cirrhosis. Your time starts now. Very good. I think most of you have reasonably got a right answer. Can we have the slide back, please? Take a note that this child has got, can I have the slide, please? This large cyst is the most likely, and the reason is, can I have the slide, please? Uh, Large cyst is most likely because it went on increasing, and thereafter it could not increase anymore. It could even burst. So stopped increasing. Whereas if it was any tumor, it would go on increasing, but a tumor that increases so much is likely to be a malignant tumor and would present with some deterioration. And same is true about the TB peritonitis, present largely with either an ileocecal junction uh, peritoneal disease or often ascites. But I've said no shifting dullness. So this is not ascites. TB peritonitis present with ascites, cirrhosis with present also with ascites, but in cirrhosis the person is not comfortable and happy. So also not so in TB peritonitis. So we are left with large tumor and large cyst, and as he is very comfortable otherwise, but more important is increase over 3 months, but stopped increasing. A tumor will not stop increasing and only increase in the first 3 months and stop. Therefore, it was a mesenteric cyst, a large cyst. Can I have the last slide, please? The last case. This was another young adult who presented with fever and skin rash for 3 days, diagnosed as viral infection. Fever settled, followed by eyelid puffiness and abdominal distension. On examination, child looked sick and had evidence of ascites. Now, your options are it's acute peritonitis, it's nephrotic syndrome, it's portal hypertension, or it's none of the above. Your time starts now. Fine. Most of you thought it was a nephrotic syndrome, but take a note of this. First thing, nephrotic syndrome has no reason to start with fever and some viral illness. That is number one. It often starts without any immediate preceding symptom. Second is that a nephrotic syndrome has does not have, yes, eyelid edema and abdominal distension, but as preceding event was fever, something is related to fever. So those of you who thought it was a nephrotic syndrome was right because there was eyelid swelling and ascites. But nephrotic syndrome present just with eyelid edema and ascites and generalized edema, not only eyelid, but all over the body, including limbs and largely feet. This child had only eyelid edema. Okay, so take a note of all this. And therefore, it's obviously not acute peritonitis because the fever would not have disappeared. It's not portal hypertension because portal hypertension is a chronic problem. And therefore, this is typically the way the dengue fever presents. Dengue fever presents with a shock, and the initial presentation is because of capillary leak, and the patient present with collection of fluid, often in the peritoneum, at times also in the pleura, and a bit on the periorbital area, and this was dengue with capillary leak. I just wanted to bring out different types of ascites, and now in the last 5 minutes, let's quickly go through the rest of the thing. Can I have the next slide, please? Well, I won't much talk about investigation because we know that we will have USG, CT scan, MRI, imaging studies, depending on what we are looking at. And then you will have to have some other illnesses to rule out if it's a liver disease, kidney disease, whatever. And I think it's not much of a problem. The investigation for abdominal distension is an imaging. Okay. While the other tests come in only when you have some specific provisional diagnosis. So we won't spend much time on that. But can I have the next slide, please? Now, next slide is for you to interact. Which of the following observations in the USG scan, abdominal ultrasound report, are reliable for interpretation? Which of the following observations reported by the sonologist on abdominal scan are reliable for interpretation? He has reported few lymph nodes. He has reported small amount of peritoneal fluid. also thickened bladder wall, or none of these are really reliable for any interpretation? Your time starts now. Good. We are largely divided, but majority of them have felt that it's none of the above. I think none of the above is the right answer, and I'll explain you. Can I have the slide back, please? Now, the few lymph nodes are normal in the abdomen. All of us have few lymph nodes. Now, ultrasonologists must give, therefore, the size of these lymph nodes. And there are no simple definitions or standard protocols to say which lymph node size is abnormal. For example, in the periphery, if in the cervical neck, if the lymph node is more than 1.5 centimeters, take a note, it's more than 1.5 centimeters and having no draining area which has an infection. Like there is no infection in the scalp, or there is no tonsillitis or pharyngitis. Then if the lymph node is larger than 1.5 centimeter, you call it abnormal. In the axilla and in the groin, it could be more than 1 centimeter. In the neck, there are common reasons for getting mild infection, and the lymph nodes get little larger over time. There are no such standard manifestations of a size of lymph node. And one point of importance is that pain in the abdomen is never related to those few lymph nodes, even if they are size of 2 centimeters or 3 centimeters. How does a lymph node cause pain? Lymph node causes pain only when it's a severely inflamed, like an acute lymphadenitis, which doesn't happen in the abdomen, or when the lymph node size gets large, like a mediastinal, like a Hodgkin lymphoma we talked of. It's a large lymph node that starts irritating the neural ending, but a small size lymph node doesn't do that. So if ultrasound reports few lymph nodes, which is so commonly reported, it's of no significance. Same thing is true about the small amount of peritoneal fluid. All of us have small amount of peritoneal fluid in our peritoneal cavity, and that is not clinically evident. But a sonologist sees it. So sonologist reports it. And when he reports it, the patients and the parents want to know why is that happening. That also is normal unless he is able to show what is the volume of peritoneal fluid, and anything age related, of course, but in an adult, anything beyond 250 ml of fluid collected could be of some significance. If that is not mentioned, it has no interpretation. What about thickened bladder wall? If a person has just passed urine and the bladder is all collapsed, the wall looks a little thicker because it's all collapsed. When it is distended, the wall will look thinner. Simple to understand. So if you see a person with a full bladder, the same bladder wall, which looks thin, will look a little thick after he has passed urine. And again, saying thickened bladder wall doesn't make any sense at all. It's not a sign of cystitis. I wanted to bring this strong point because when you next time ask for an abdominal sonography for an abdominal pain or an abdominal distension of unknown cause, you must tell the patient and parents before they go to sonologist that some of these abnormalities seen on a sonogram may not have any relation to any pathology. Because after you get the report and you have told them, oh, don't worry, now you start defending your statement of not to worry. The parents believe that, oh, now you are just trying to defend your own wrong diagnosis. I make it a point every time when I ask for an abdominal ultrasound to tell the parent, don't read the report and start getting worried. Often normals are seen and they report. Therefore, today even sonologists have learned the trick and they write below the report, please correlate clinically. And I wanted to bring this point to your notice when you ask for an abdominal USG. The next slide, please. I won't all muck about treatment either because all this treatment is of no great use unless you find a cause. If it's a gaseous distension, you need to find the cause why it is. Is it due to intestinal obstruction? Is it due to intestinal malabsorption and chronic diarrhea? Is it due to whatever the cause? But what are the symptomatic treatment? They are not of great use, but yes, we use carbonative, you use natural products, you use simethicone, yes, as an antiflatulent and antacid. And for constipation, we have already discussed on one of the webinars on different types of anti-constipation medication. And I think management of abdominal distension is not symptomatic. You have to find the cause and then treat accordingly. Last slide, take home message. Detailed history offers a clue to a probable cause of abdominal distension. Acute is an emergency, often surgical but may medical. Chronic abdominal distension may be waxing and waning or gradually worsening. That makes a lot of difference. Plater species and fluid present in generalized abdominal distension while organomegaly and lumps come localized. And don't forget the functional problem is not uncommon today. And management is really symptomatic and specific. I think with this, I will hand it over back to Dr. Anupam. We are almost through our 1 hour session. Back to Anupam.
It was a wonderful session, and many questions are trickling in. With your permission, may I take few questions, sir?
Yes, please.
One is how to differentiate between whether abdominal distension is due to gas or any serious pathology.
Yeah, I think if it's a gas, then it's generalized and there is a tympanitic note. If it's a fluid, it's generalized, it is a dull note. And if it is a localized situation, like a feces, then the distension is generalized, but often at the other end of the lateral end of the abdomen, like in colon. First, the rectum and the descending colon is loaded. Thereafter, the loading can occur even in a transverse colon, thereafter in an ascending colon, and finally all over. In that case, you can almost palpate the hard feces in the abdomen. So it's not difficult at all on differentiating on palpation.
Next question is how to differentiate between generalized distension caused by flatus, feces, or fluid.
Yes, I said just now that one is on history, waxing and waning, very important. Flatus is waxing and waning every day on and off as he passes gas. And if he has not passed gas and his flatus distension, it's an emergency. Intestinal obstruction of some kind. Of course, there are other symptoms. Often constipation, when it's relieved, the abdominal distension is relieved and then builds up again over next 24-48 hours. But the fluid is not much of wearing like this. So always ask for waxing and waning and then palpate and percuss. It's easy to differentiate between all of them.
So we'll take another two more questions. How to differentiate between common causes of ascites?
Yes. I think when you see ascites, you want to know whether it's a part of a generalized edema, like a nephrotic syndrome, or also like a capillary leak syndrome after a dengue. Both are generalized, but nephrotic is really massive generalized. all over. Whereas a typical capillary leak is largely mucous membrane collections like peritoneum with mild periorbital edema. So small difference between the two. These both the patient are easy to differentiate not only by the extent of edema, but capillary leak is a very sick person, whereas a nephrotic is a very happy, comfortable person. So that much about a ascites with generalized edema. But if it's ascites without edema, then you have two possibilities. One, is it a portal hypertension and the common cause being a cirrhosis? This patient is chronically sick and has not been doing well for a long time, and he has a large firm liver, he has a spleen, and he has also ascites. That's one cause of ascites without any obvious edema anywhere. But he may have a mild edema phase because of hypoproteinemia caused by cirrhosis, but no puffiness of face. Then tuberculous peritonitis can cause ascites. Again, he is a sick child, but not as sick as chronically sick, but he has also often fever and he has tenderness over the abdomen. Whereas the cirrhosis with ascites doesn't have tenderness on the abdomen. So that's another cause of ascites without any edema anywhere else. And these are the main. Of course, malignancy in the abdomen with peritoneal involvement also is a sick child with maybe a mass somewhere in the abdomen, which is not easy to make out even in presence of ascites. So these are the common causes. Acute peritonitis, very sick child, tuberculous peritonitis, chronically febrile sick child, cirrhosis, chronically sick person. And lastly, don't forget to rule out a large cyst, which looks like an ascites, and the person is absolutely comfortable.
So another very interesting question, I think the last one, though many questions are trickling in. In case of large mass in abdomen, how to know from which organ it is arising?
Very good question. I think it's not easy when the mass has become large. It could have come out from any organ, largely in the middle of the abdomen. If it was a liver mass, it will be reflecting only on the right hypochondrium, but may grow downwards inferiorly. If it was a splenic mass, it will be mainly in the left hypochondrium, will go diagonally onto the right iliac fossa, but not all over. If it was a pancreatic malignancy, you will not feel a large mass because much before that there will be a lot of obstruction to biliary tract, pancreatic duct, etc. So the large mass largely comes from two, three organs. One is the kidney, Wilms tumor, nephroblastoma. Another is an lymph node, Hodgkin's lymphoma or a TB lymphadeninitis. And third, in female, it could be an ovarian mass or an ovarian tumor. All three look alike when they become large. But the rest of the syndrome might differentiate one from the other, but it is nearly impossible by a clinician to push a hand and say, yes, it is one or the other. But if the mass is spreading all over equally, it is largely coming from the lymph node. If it is not crossing the midline, largely it is coming from one kidney. And if it is largely in the inferior part, in the lower pelvic part and the lower hypogastric part, then it's likely to be ovary. But I'm sure when it becomes large, all look alike, all are dull on percussion, all may be firm, all may be mildly tender, and you have to image to find out what is.
So, though many questions are trickling in, so I'm sure Dr. Amdekar will cover all these questions with answers in the next issue of GP Clinics. So it is more than an hour into the discussion. Let us close the session today. So thank you, Dr. Amdekar, for this wonderful session. We hope this interactive session would have made learning interesting for attending doctors to help empower their practice. On behalf of GP Clinics and docislive.com, I thank all the doctors who have attended this session. Please note the date for our next webinar, which is on 9th of July, 2023, Sunday, 11 a.m. same time. The topic would be headache, an invisible problem. So thank you once again to all of you. Good day.
Good day to all of you.